I'm with the healthcare team, the rehab team at Sentara Northern Virginia Medical Center as part of the Sentara healthcare system. And so we're extremely excited to have them with us tonight. Joining us, we have Michelle, Dr. Michelle Figueroa, who is the rehab manager at Sentara Healthcare and the Sentara Northern Virginia Medical Center. And the team lead of that team, Rachel Lewis, occupational therapist, is joining us tonight as well. Jasmine Dockett is with us, as well as the occupational therapist that started and championed these services to be offered to individuals after birth within the hospital before they go home. We have Dr. Sarah Sidar, who's with us as well, who's a clinician, who's an assistant professor for Masters of Occupational Therapy program. We have quite the team. Without further ado, I just want to first of all thank your team for being here. We often don't actually get to see our acute care therapy staff showcased. We're kind of hidden. Our pictures are often not displayed on the website. So to get you out of the system, first of all, for this discussion, I cannot tell you what an honor it is, first of all, to highlight your services, your hospital, for pioneering a program that's going to help so many individuals during the most vulnerable time of their life. But I think all of us would really like to just get a sense of how this all came about. I know bits and pieces, but feel free. I think Jasmine, take it away. I'd love to know how this came about.
So at Trade, I'm a NICU occupational therapist. So I work in the NICU. So pretty much this all stems from my time of being in the NICU. So obviously I work with the infants, but I also work heavily with whoever's at bedside, whether that be dad or mom. And I like to have them involved in my session as much as possible. But what I noticed with moms who had C-sections, obviously their mobility was not that great because they just had a huge abdominal surgery. I also looked at how they are interacting with their baby, how they're lifting their baby to them, breastfeeding positions, just kind of all the physical aspects. And then just curiously, I asked how they felt mentally, just a simple, how are you today? And then that opened up a lot of just different things of how they were feeling. And so it just got my wheels thinking. And I was like, oh my goodness, why are we not seeing this population? And from there, I started to do my own research. And honestly, that's how I found you, Rebecca. And I was like, okay, well, we don't even have to reinvent the wheel. There's kind of something that's already there. So I brought that attention to Michelle, who's our rehab manager. And then from there, I gave her my pitch of how I was feeling, of how much occupational therapists or physical therapists need to be in this population. And I don't understand why we aren't. And the why is what I pitched to Michelle. And I was like, if you can tell me why we aren't seeing these patients, then you might have something. But she couldn't. So, and then from there, we took it to our executive directors, and we had to present to them and get their blessing and get them on board. And they loved it as well. Honestly, every single time I presented this to somebody, everybody's loved it. There hasn't been any really pushback on why we shouldn't. So from there, then they were like, okay, we don't want this just to be at Sentara, Northern Virginia. Because that was my thinking. I thought it was just going to be at our particular hospital. But Sentara has 8 hospitals. And our lead said that she wanted all of the hospitals to do it. And I was like, oh, okay. So, and then from there, that's how things really got going, and different pieces started to come in. So that's really like how it started.
Yeah, I was going to say, Jasmine she came to me and gave me like this whole like pitch, like she said, and I'm a physical therapist by discipline. And I don't have a ton of experience in that field, in that area of practice. And yeah, it was like light bulbs coming up over my head, turning on like, And so one of the things that we ended up doing was I asked Jasmine to go talk to the nurses on the floor and say, get some feedback from them. What are they doing? Are they educating on bed mobility, on positioning and things of that nature? I kind of had a hunch of what the answer would be, but really trying to vet it through thoroughly, so that when we do present to our executive leadership team, which Kathleen Hardesty is on here, huge plug for her, because she was incredibly supportive of this. We wanted to make sure that we presented a very comprehensive package to them, really looking at the evidence that's currently out there, and unpacking it as far as where we currently practice. And it's not really considered, no one blinks an eye of us evaluating a patient who has shortness of breath and has a COPD exacerbation. But here we look at a mom who has had, an incredible surgery, gone through major trauma, and we just have this cultural acceptance that, well, yeah, mom should be fine. She needs to go home. She should be happy, et cetera, et cetera. So as we all kind of presented up to the next level, it was really interesting and fun because you just saw light bulbs going off on everybody's, like, why aren't we involved? Like, this is bananas. This is crazy. And so I think that the fact that Jasmine started this whole thing and she was very well prepared in each step of the way, as we added different components to it to really hardwire and create a incredibly solid sound argument for the case, it really paved the way very nicely. And, we had incredible support from our executive leadership team. They were really basically said, do what you need to do. Let's get this going because there is an absolute need for it. So it was a really awesome experience that you just don't get too often, in healthcare and when you're implementing new programs and whatnot. So it was a great experience.
So I have a question for you, Michelle, because your reaction was so unusual. And I'm sure you could probably appreciate this as a rehab manager. Generally, our barriers are that we have such a huge heart, like Jasmine. We see a need in certain patient populations. We want to start a new service line. But in terms of the bandwidth, in terms of the triage that occurs, we know in acute care, biggest barriers are, could we potentially support the staff to see now this new population we haven't been seeing, adding them to our caseload? And then also, with just the census, being so unpredictable, would we be able to meet that need consistently? Birth happens 24/7, right? Mm-hmm. You know that even from the NICU, Jasmine, is that a lot of these individuals have a very quick discharge, but yet once they leave the hospital, they're discharged, but they're in the NICU, your services for them stops. You might recognize a lot of a mom going through, maybe incredible pain while she's in the NICU, trying to bond with her infant, but you can't do a lot for her at that point. So, Michelle, how did you, I guess, initially, like, what was that kind of gut reaction telling you? Could you see your team being able to accommodate the need?
Yeah, I think a lot of this really was, how could we not? It's really, we've got to figure it out. We got to lay it all out there, and that no is not an option, really, when it all came down to it. And I think part of that was really, at the real breakdown of it all was, doing our homework and being able to produce the data from the year prior and be able to track it and really be able to lay out some good groundwork for logistically, what does it look like? Let's paint this picture very, very clearly of the volumes that we have. And truly, to your point, like, what are we realistically going to be able to provide with that narrow time span? And I think that that's where right now we have on the 18th of September is when we went live with the program at Northern Virginia. And it definitely, you're right, there's prioritizations and there's trying to figure things out on a day-to-day operational side of it. But, they're just as important as any other patient, the total joints that come in or the stroke that happened the day before. It's really looking at, how do we meet the need now? How do we produce the data to show that, maybe we do need more support, more FTE, whatever that case may be. But right now, just looking at what are the trends before, how can we meet it now? And really understand too that it's not it's progress, not perfection. And that's the biggest thing at looking at. It's not going to be perfect right away. And I think sometimes that's the hardest thing and the biggest barrier that we encounter is that if we can't do it right the way we perceive right being, then we just kind of give up. And so I think all of us walking through this implementation process, realizing that, there's going to be a lot of lessons learned, and we're going to be able to share this across to other hospital systems that are, going to be following in our footsteps. And we've learned from those that have gone before us as well, and really trying to figure out, where does that happy medium, so to speak, land? So I hope that answers the question.
Oh, it absolutely does. Sarah, from an educational standpoint, we know that in terms of evidence-based practice, research supporting occupational therapists, for anyone who's at risk of readmission within 30 days after discharge, there's more of a focus on occupational therapy practice, in particular for reducing readmissions to the hospital. When you hear or the question is asked, what evidence supports occupational therapy, specifically occupational therapy, and I want to focus on that because this is an OT-led team. What evidence supports OT being offered to this population as early as the hospital stay after birth? What's your initial response and guidance for your students?
So I am a research geek, so I'm so glad you asked that question. So I speak to a couple of different things because part of my involvement in this is I do there's more research that needs to be done, definitely, and things that we know intuitively and instinctively. The benefits that we as OTs or as a rehab team, OTs and PTs, the benefits that we can provide to these people, we know intuitively that those benefits exist, but we need to have the data to back that up. And some of the specific research, what I draw from, because we don't have this, as much specific research like on this distinct population, this distinct intervention, which I'm hoping to collect data on and contribute to that body of research as we move forward. But I draw from, we do have a robust evidence base to show that occupational therapists reduce chances of readmission rates across a broad spectrum of populations. One of my favorite research studies was a huge study of Medicare patients. And of all the factors, and it wasn't even a study focusing on occupational therapy, it was a study focusing on factors affecting readmission. And so they looked at tons and tons of factors. They looked at, increasing spending on occupational therapy staff, but also, surgical procedures and social work and all kinds of different things. And really the headline of the article was OT reduces readmission across multiple diagnostic categories. And so that's one of my favorite articles to cite to show that our involvement on the acute care team really is key in terms of improving outcomes and discharge status of our patients. And research similar to that, since that my favorite study, I think it was 2017, was published. Since that time, there have been multiple other research studies across other populations within the acute care setting that have shown the same. So I think that's one piece of it. Also, having just recently finished my doctoral capstone and having done a deep dive into the literature, there are also other studies to show that occupational therapy intervention can be effective in terms of reducing things like repetitive stress injury relating to mothering occupation. So like neck pain, back pain, wrist pain, related to things like breastfeeding, positioning, lifting, things like that. And so when I draw from some of those, it's, while I would love to have, as I move forward and hopefully research more, I really am trying to put together more evidence specific to this population in this acute care setting. There's definitely other research and evidence to draw from that can support our role in this area, for sure.
Thank you, Sarah, and congratulations, by the way. That is huge. That's huge. Rachel, when you hear Sarah describe, even those interventions, say the population that's at risk for neck pain, shoulder pain. Now I think about moms after C-section. One of the things that they complain a lot about is shoulder pain, but it's actually because of just the gas, the incredible gas pain that's referring to the shoulder. That could be compression of the phrenic nerve, compression of just, where the diaphragm is still sitting. And then also that putting them at risk for post-op ileus, all those kind of things that we see. When you think of kind of the biggest question in the room all the time is, well, what's the difference between occupational and physical therapy services when you're addressing those either musculoskeletal factors or when you're addressing activities of daily living, which chest feeding, breastfeeding, newborn care are? What's your initial reaction to what do you respond to for that question? And what's the difference between OT and PT?
Yeah, I actually love getting that question. I really do, because I love being an occupational therapist, and I love advocating for the profession and what we can do for our patients. So when we go into the room, I love to be able to, in acute care, I feel like we had to build a rapport really quickly with these patients. So in that building that rapport, I'm learning what occupations are the most important to this mother. So I get to explain and deep dive a little bit more into what my role is. I can touch so many areas that a lot of people don't know. And as the patient, they also may not know as well. So I will get to, okay, you're having trouble getting dressed. I can address lower body dressing. I'm having so much pain. I can address pain, reducing your pain, mobilization, helping to stretch, applying your abdominal binder. There's so many things, avenues that we can talk about and address. And one of the biggest things that I've loved talking to patients about is occupational therapists. We have our roots in mental health. And I know a lot of people, even outside of these patients, don't know that we can address mental health. We can address the depression, the anxiety that may come along with having birth, giving birth. So it's one of the questions I love getting, that I've grown to love, because it happens all the time. What's occupational therapy? And I like getting to talk about that with my patients and building that rapport and having them better understand what it is that I can provide to them.
So this is popcorn style. How do you feel, OTs? And Michelle, you can kind of appreciate this, but how do you feel if mom is up and walking, passing gas, she's fine, and so PT clears for OT? Meaning physical therapy writes off the OT is not needed at that point. Neither are any additional physical therapy services. That hasn't happened, right? That never happened.
I see them twitching right now, actually.
Yeah, I think I saw, there's something with the eye. Like Jasmine had a visceral. Jasmine, what's your initial, what's your gut? Because we can even go down a rabbit hole and discuss why that.
I would say if that is what the only thing a PT is looking at, then they're not doing their job either. Because as a physical therapist, from my colleagues, they always get annoyed when nurses just say, you guys just walk people. So if you're really discharging people just because someone's walking, but really, as an OT, you look at the holistic approach. You're looking at the whole person. So yeah, they might be able to walk, but are they able to necessarily do the other things that they need to do? For instance, it could be easily as dressing, what we've been saying. It can be how they care for their baby. How are they lifting their baby? How are they breastfeeding? How are they changing the diaper? There's so many different IADL tasks that a mom has to do, especially if they're a new mom. They've never had to do any of this stuff because even if they had their own nieces or took care of other people, it's different when it's you doing it. And especially if you had a C-section. So being able to kind of bring everything down and just ask them, honestly, what do you need from me? So that is how I go into the room. I have an idea of what I want to do, but I really try to have a dialogue with them first. And then I try to approach whatever they want to do the most and when they go home, because we could be in the rooms for hours. There's so many things that you can address, and we're just not going to be able to address everything. But whatever the mom feels like she needs most help with, that is what I'm going to address. And I'm going to listen to her and just hear her, because we might be the only people in the room who is actually hearing her and hearing what she is saying. They might look fine. A lot of the times our patients do look fine, but they really aren't. There's other things that are going on that it's our job to figure out what they need.
I think too, kind of piggybacking on that, Jasmine, as we worked through this process, we had some very dynamic, lively conversations within our own department where it was PT and OT. And it was a little bit of a turf war trying to figure it out and to open our colleagues and their peers' eyes up to all that occupational therapists, their skill set, incredible skill set, that with this specific patient population, it's just such, it's like I feel like it's such a beautiful marriage, because when you look at the occupation of motherhood alone, I mean, sky's the limit. And how far, and really to Jasmine's point, really identifying what is the most important thing for that mom, listening to her, being able to really address and give her tools that are practical that she can go home and start applying to make life, that's one less thing that they have to deal with. I know for myself, I had 2 C-sections, and it would have been amazing to have that experience and to have, even as somebody who has that knowledge and skill set, when you're a mom in the bed, like all that stuff goes out the window. You really do need help. You need somebody to look at you as a person, as a patient, and to be able to listen to your needs. So we definitely Jasmine took a lot of those conversations, and she did a fantastic job, as well as Rachel, unpacking that for our peers and allowing them to really see outside of maybe what their perceived thoughts on what that assessment looks like when you are working with that patient population.
That's pretty profound. And well, Michelle, thank you first of all for sharing your experience, 2 C-sections. So you may actually, this may be another question for you, but then I'd like Sarah and Rachel to chime in. Do you think that at the time, however, whatever state you were in, maybe an OT or a PT evaluation during the hospital stay would have been too much information?
Me personally, no. I think one of the areas that I really personally struggled in was pain. And just having somebody to walk me through that and hardwire that for me, because we're also, as therapists, as healthcare workers, we're terrible patients, self-admitted. And to have somebody really look at you as if you don't have any medical background, they wouldn't know necessarily. I don't personally feel that. I also felt that, when you go into like the ergonomics of positioning with breastfeeding and everything that comes along with that, my goodness, I would have loved to have had somebody show me, because I was doing just about everything you could possibly do wrong. And I wasn't terribly successful at it, and I think that it's unfortunately, as you talk with other women, you realize that my experience is not abnormal. It's the norm, unfortunately. So it really speaks to the impact that we can have.
And I wanted to say it was it's been beneficial. Some of the patients that we've already had that I've observed, Jasmine, and I've gone in myself, that these patients, they are in just so much pain as soon as you walk through the door. So I may not even go into the room explaining that that I'm here to do therapy. I'm here to listen to you. Number one, first off, if you're Jasmine was a prime example. We walked in, this woman was in so much pain and she just wanted to have a bowel movement. So Jasmine went in initially just to say, well, let me help you. Let me help you to reduce the pain. Let me help you try to get onto the toilet. She tried to walk her through it before explaining what else that we could be addressing, what else we're doing as occupational therapists. We went in just listening, and then we go from there. So I do think that it's just beneficial just to go in talking, but not necessarily it's too much information for them right off the bat if we take that approach.
I think Rachel brings up a really good point, because as our instinct and how we're trained and how we approach our clients from an occupational therapy standpoint really is what matters to you. So sure, kind of like what Jasmine said, we have a little bit of a framework of here are the things that I'm probably going to cover in this session, but ultimately you walk into that room and it's a clean slate. And so too much or too little is really dependent on the person that's sitting in front of you and what they need. I think there is a little bit of danger to going in there with a preconceived notion, or here are the 15 handouts that I'm going to give you based on what I think that you should know, which, half of might not be relevant. And, the other half, they might be, again, in too much pain to even digest. Right. But I think when we walk in the room and we start from, what do you need? And I think Michelle really made a really good point as well, because just again, having had 2 C-sections and 1 vaginal delivery myself, you completely lose your identity as a individual. You're a mom. Like I wasn't Sarah anymore. People don't even call me by my name. You walk in the hospital room and it's like, hi, mom. And people forget that you're a person that just had a surgery and just had a major life transition. And to have one person walk into that room and say, what do you need?
Mm-hmm. Sarah, you touched on a nerve there, because I think probably what I struggle with the most is someone taking either their own experience, whether it was a birthing experience where they were so tired, they were so fatigued, and now they're a clinician and they're thinking, no, this would be overwhelming for the mom. I don't think this is necessary. Or them taking an experience that, that person did deny services, and then generalizing the whole population. And I think that we run the risk with any patient population of using these isolated experiences and then generalizing the whole patient population that we're treating, whether it's someone with COPD, or whether it's someone with shortness of breath after birth. When we forget the identity of the individual and everyone's mom, we're walking in the room, we don't know their name, maybe they don't identify as a mom. In my case, the last webinar I did, I spoke about a 13-year-old girl who did not identify as a mom. She had an abdominal surgery. She didn't even want to acknowledge it was a C-section and that she had a baby just, beforehand. And so you have to really take a moment just to kind of like sit with what you just said for things to change as drastically as they did in your health system. And I know that we have clinicians on here where things are moving very slowly. They're met with a lot of barriers. One of the questions that I'll read to you all in the chat, because there's quite a few. So this next round will just be questions from the audience that's joining us live tonight. But one of the questions really had to do with, what do you do when you have colleagues who don't want to see this patient population? And that's weird for me. I mean, my practice is outpatient women's health. And so when I came into the hospital, I was under the assumption if I have an order, I don't say no. I don't treat anyone who's homeless. I mean, I wouldn't think to discriminate against the patient population. So I'd like to kind of open up the floor to even that reaction of what I just said. What do you feel about, your colleagues? And Rachel, you're a team lead. I'm assuming, I don't want to assume, but is it over PT and OT?
Yes.
So you're a team lead of a rehab team of PTs and OTs. Should we feel like it's okay to kind of deny services based on that person's either gender, their pregnancy status, even our comfort level? What does that look like in acute care if we're allowed to just do that widespread?
Yeah, I would say, I'm very fortunate. We have a really, really great team here, and all of us, we don't go in kind of taking those things into account. We really want to help provide the patients with the best possible care. We haven't had a lot. I can't say that we haven't had a lot of pushback, but we have made one of the biggest steps that we've done to try to increase those services or get our colleagues to buy into this is really good. This is something great happening. One is, like I said, Jasmine starting this program, seeing all of the positive feedback that she comes back after seeing those patients. It's enough to have touched so many of my peers, my coworkers, that they want to be involved. They want to help as well. They want to learn more. They want more research. They want to be involved. So now we're trying to take that energy to spread it to the rest of the hospital, the other teams, the nurses, the doctors, to get everyone else excited in what is happening and how big of an impact occupational physical therapy can make with this patient population.
Thank you so much, Rachel. And Michelle, have you encountered any therapists who, and please be like as general as possible, that for one reason or another, it could be another patient population. It's just not comfortable treating that particular patient population. How do you navigate that and also navigate this new program?
Yeah, I think that for myself is really getting into the nitty gritty with it, with any individual who has reservations, trying to identify the why behind that. Is it just the uncertainty of something new? It changes hard. Not knowing, is it because you don't feel like you have the skill set, or is there something that's triggering underneath, or that's a very personal experience? And then being very sensitive to that as well. Two very different things that I feel like they have different ways in which you would manage through it and work through it together with the peers. But what I have found is that, I'd like to say everybody would just jumped on board and was ready to rock and roll from the beginning, but that's not reality, and that's okay. I have found that some of my peers that have struggled with it, it really, when you unpack it, it's more that fear of the unknown and not feeling comfortable. So it is projected out in ways in which that they don't realize necessarily, that that's the reason behind it per se, but that's a very different thing that we've been able to now walk through, break down, and be able to hand off lots of different tools, support. And I think too, just realizing that they can make a mistake and it's okay. Like, we're here to support each other. We're not going to get it right the first time. No one does. That's totally fine. It's going to help us navigate through different areas, so I think that that's been pretty, at the beginning, it was a point of frustration for myself. But as I began to understand the process, and when you're looking at something so large and the end goal, we all want the end goal to be success. But walking through the different steps of it to be able to, kind of to your point, like not bring your own bias into it, but to really listen to the people, the person, and figure that part out.
I want to say, I just want to comment to Michelle's leadership in her approach, because I feel like that can't be undervalued. When you go to somebody who gives you pushback, and instead of your knee-jerk response is typically, well, let me defend why and try to convince you of why this is the right thing to do. And her approach of leading with curiosity, and really kind to dig into, like, what is your reservation about that? I mean, I have learned a lot from her leadership style from that standpoint, and have just recognized how effective that can be in getting people's wheels turning in a way that's so much less defensive. So I just really want to give her credit, because I think that's really important when people are feeling that kind of pushback.
Michelle, we have a question for you, kind of really along the lines, and it's coming from Dr. Erin Lacati, who's joining us from San Antonio tonight. And she started a program in a large health system as well. And so she wants to know, what advice would you have for therapists that are working in systems that are not being supportive of seeing this population? She has some follow-up questions about approaching a rehab manager. And just from what Sarah said about your leadership style, it's rare. It's really rare. So what advice would you give to therapists who are not being supported by their rehab managers?
Yeah, I think that, I mean, and that is tough. For me, I've been very lucky and blessed, because I myself have been so supported with my leadership above. Kathleen Hardesty and Christy Haney both are on, and having support in that relationship has allowed me to really push and grow, and learn from them as well. I think that it's really trying, if it's that balance between, you always want to be professional and you don't want to misstep per se, but you got to find an ally. And I think that's, it just starts with one sometimes. And I think, when it's your passion and you've identified this as an area that you really want to make your biggest impact in, I think sometimes just being very steady with, at that moment, your effort and the result. You can't use that as like a linear relationship. Like, you may have to put in a ton more effort, and that's okay, because the reward is going to be gigantic in the end. And I think too, as we all are working through different timing with implementation, that we all are here to support each other. It's an amazing community that we have, and knowing that, maybe we can go through different tactics. Have you tried this angle? Have you worked in this, sense? Have you been able to pull all the data? Different opportunities that you can have to try to get your message, at least to the point that, okay, and I think accepting the fact that even if that leadership isn't 100% on board, but it's enough for you to get to that next step, and then keep growing your momentum through it. I hope that answers the question.
So much. Yeah, absolutely. And this is for the rest of the team. Sarah, please chime in from a research standpoint. If there is anything that you can kind of give advice to, and this is kind of part of that first question, to therapists who say can't afford additional training, or their hospital system is not supporting them with additional training, is there anything that you can recommend that therapists hone in on skill-wise to be able to treat populations in the hospital during high-risk pregnancy, immediately after birth? This is a big hot topic because, again, there's not a lot of information in the literature, right, on our therapy services, on rehab in particular, for this population this early on. What advice would you give to therapists who are listening in, who want to serve this population, who want to hone in, but they just don't know where to start?
I would say you're already doing it. You just don't know it. In the way of, when you're seeing different populations, we are the ones who usually take vitals at all different parts in your session. You have to adapt with with the patient that you're seeing. Sometimes they can't get out of bed, so then you are doing a bed level treatment or a bed level eval. So that can correlate kind of to the antepartum stage of moms who are on bed rest, and you have to figure out what are they allowed to do, or what can they do. I think that we just have to get out of the mindset that it's a different population and I just can't do it because it's a different population. That's really the only huge difference, is that it is a different population. But as therapists, we're already doing a lot of that stuff in our sessions. Yes, I think you do still need, well, definitely, you still need to educate yourself further on that population that you're seeing. But I feel like sometimes we're not, I guess I'm trying to say is that we see a lot of different populations in the hospital anyways. Like, it'll be a new diagnosis, you've never heard of it, but it's an eval that you're going to go see, and you look it up at that time and you go see them, So we're already seeing that on all throughout the hospital. You don't know every diagnosis that's out there that the doctors are ordering you, right? So to me, it's really your mindset, and not that you don't have the skill set to be able to see that population. And I think as therapists and as working in the health system, you should always be trying to better yourself in the way of educating yourself, because medicine is always changing. So if you're a stagnant person and you don't want to change, then honestly, this just isn't the setting for you, because it's always changing.
Acute care is always changing. That's true. For Sarah and Rachel, Lisa Nolinsky asked an excellent question. Yes, this is a different population, but you're doing the same fundamental thing as you would as a physical or occupational therapist. But she's asking specifically, what does that look like? Like, what does that actually look like in the room postpartum, with an acute care postpartum visit? There's also a manager, I believe, a director, who's in home care. And she wants to know, in your assessment of your evaluation, your plan of care, are you recommending that this individual also see an OT or PT in the home? And so can one of you walk us through what an evaluation would look like with this patient population?
Yeah, I do think Jasmine did say a lot that was that was really helpful to this. Is like it's ever changing. Like and you are already doing a lot of this stuff already. If you're in the acute care setting, working with your patients, you're doing a lot of this stuff, taking vitals. You may have to change your plan on the fly, and I feel like that's what happens a lot. I go in, I'm catering my treatment session, my evaluation does stay pretty consistent, but I may have to change it midway, halfway through, to cater to the mom of what is going on right now in real time and what is the most important to her. So, I mean, I do, when I'm starting off an evaluation, I am still typically asking my prior level so I can get a better understanding of what the home setup looked like before, who may be the support system, what is mom going home to? And to answer that, and again, it may be changing. I may want to get the patient up, but then they're not stable enough to do that. So I may have to change what I am going to do in that session, and that's what the rest of it will look like. In terms of discharging, I will still, based on what I did my evaluation, if I think that mom still needs a little bit more after at discharge, I may recommend a home health. So far, some of the patients that I've seen, they are long sessions, but I get a lot of it accomplished of what mom wants and what I feel like what I needed her to do to go home safely. But home health may be a recommendation if I think she may need more, or even outpatient.
Mm-hmm. Mm-hmm. Yeah, I think both Jasmine and Rachel really spoke beautifully to what this looks like. I will say that one of my fascinations, kind of my curiosities, is how we have PTs and OTs that feel comfortable in an ICU with literally drains coming out of people's brains. You know, like this is the extent, right? Or like their lungs are actively draining fluid out of a tube. You know, and we're like, yep. We got this. We're going to go see that patient. That patient's sitting at the edge of the bed and they're brushing their teeth today, you know? And yet we take some of these same conditions, you know, we've got like things for blood pressure, high blood pressure risk. We've got risk for stroke, risk for, cardiac dysfunction, things like that. And we put that in a pregnant or a postpartum body, and all of a sudden our minds are like blown. And it's like, let's not overcomplicate. A lot of time, the simplest, it's like you're making it. Not to say that there's an additional training you need to do, not to say that there, like what Jasmine said, there's not, extra things that you should, take your time to learn about, but like, let's not make it more complicated than it needs to be. A lot of this is what we're doing every single day with a lot of other people. We just have this additional occupation of now vast majority of them have a brand new infant that they're going to have to take care of. And we got to add that into the mix. But it's no different from when I go into a room and say, oh, you cook your own meals, or, oh, your job is, driving a forklift. Okay, let's figure out how we're going to get you back to doing that. Right.
That is so true. Adrian Chavez actually asked a really great question, because I wouldn't ever think of this being an issue in the ICU. We're taking vital signs with every position change, just even after a few, minutes of doing a certain activity, sitting on the edge of bed, we're constantly looking at vital signs. But yet there's a question on whether or not you find any pushback from nursing for taking vital signs with activity. Our nurses essentially don't know what to do when the blood pressures with activity go out of parameters, and they are unfortunately viewing it as us giving them more work to do. That's currently the pushback that she's receiving.
First thing I think of there's a lot of opportunity for education and being able to script to them how your role is supporting them. Just from the jump. To really think about it. And I will say it reminds me of one of the first patients that Jasmine saw on our unit here, came with preeclampsia, and she went through the different positional changes with minimal exertion, and mom's vitals fell well outside of the norm. And it was really interesting, and Jasmine, correct me if I'm wrong, the communication immediately to the nurses, to the doctors, I think they were very, I don't want to say surprised, but I think that it is becoming more enlightening to them, the contribution that we are going to be bringing to the team, and the quality of care that we're going to be providing is really going to accentuate what they have done. And they've done a great job, but we have a skill set too that can really help impact. Unfortunately, I know that, we've talked quite a bit about in previous conversations, like the mortality rates and whatnot, and how they are on such a high rise that, the skill set that we bring to the team can hopefully mitigate some of that, and catch those things. So, Jasmine, correct me if I said anything.
No, that's completely correct. With that particular patient, I think as us therapists, what we're really good at is explaining things to the patient so they can understand it. So, for instance, that particular patient didn't know what preeclampsia was really. So I was like, oh, okay. So we got to start there, like of really describing what that is. And then as I was taking her vitals, what all that meant, and with activity, what all that meant to her. And she was really nervous because that's also why she went into labor early, was because of her preeclampsia. And she was saying like, oh, it's just because, like, she was saying her blood pressure was going up just because she was nervous. And I had to, really explain to her and kind of piggyback what the doctors and some of the nurses were telling her, and to put it in real time so she could really grasp it. And I think that's the little difference that we have, is that we're able to have the patients do things in real time, when other times when the doctors or the nurses are talking to them, they're just saying it to them, but there's like no hands-on activity with it. And then finally, after that patient, I was able to talk to the nurse, and then she went ahead and talked to the doctor, and she ended up staying an extra day.
So you actually lengthened her length of stay.
Yeah. Mm-hmm.
Which again, the assumption is, well, we're providing a better benefit to the hospital if we shorten length of stay.
Yeah.
But sometimes Sorry.
I think one of the reasons why they did that is also because a few days ago, they had somebody come back in. So they were discharged, but they had a readmission because of this. It was like almost like the same story. So I think they were a little bit more like, okay,
Yeah. Michelle, you're probably also like better at this than me in explaining it, is that there's a cost benefit analysis that's done when you're able to save a system money by preventing readmissions, in addition to helping them increase revenue and things like that. And so another thing that we can talk about, but in terms of your team, there's a direct question from a therapist that I actually had the privilege of listening to today, give a presentation to her department. She's here pursuing her finishing up her capstone. And so her question, kind of along the lines of this, right, is, are there any opportunities to conduct pre-birth education before individuals come into the hospital? Because the sheer volume of births that's occurring, right, in these large medical systems, there's just not enough therapy staff to see everyone. And so do you see that on the horizon for Sentara Health?
Yes, I think that, and that is an excellent point. Just like comparing it to like our total joint patients who are required to take a class before they have their joints repaired or replaced, to walk them through all the bits and pieces, therapies involved with that. And I know through COVID, that was one area, the classes that were given and offered before birth were not happening. They are now being going back to live, instructions and whatnot. So there's some good opportunity with that. And I think that anytime that you can give out that type of information easily accessible, have that be the first time that they listen to it. And then when they're there, that's the second time, and you're really hardwiring so that, the chances and probability of them being able to carry that through, in practical, purposes when they leave the hospital. I think that there's a lot of potential for that. I know that one of the longer term goals that we have is to put together a packet of information. And thank you, Rebecca. She's done a fantastic job helping to guide us through that. And I think that there can be some opportunities with implementing something of that same nature at that type of, at that setting as well. So yes, I think that there's some really great opportunities that could be tapped into.
It almost feels like, hey, there's a lot of pressure on you guys to have the answers to all the questions that I likely won't get to, but what I'll do for our live and recorded audience is go through these, and any that I didn't get to, I can always send to your team. But that being said, to kind of bring this full circle and wrap up our discussion this evening, you're not responsible for having all the answers right now. You're starting something new. We never expected that of the first system that decided we ought to see individuals after stroke a lot earlier than we're seeing them right now. We ought to see individuals after total joint replacement, maybe day of surgery. Any big change with any population, right, takes time. And then that time gives us enough data with larger hospital systems implementing those changes to then research and see what went well, right? It's usually not the cart before the horse, where we're asking for research before any of us have even tried anything. That's really rare. And I find that is particularly curious in this population, that we're demanding data from you all right now to tell us what works. And then we'll do it. And then we'll see them. And then we'll walk into the room and then we'll ask.
Trial and error. That's what works. Trial and error.
Trial and error. If there's any advice, any recommendations, any words of encouragement, any proposal or pitch that you have to the audience, Jasmine, I'm going to start with you because you made the pitch to Michelle and you started with why. How would you now turn to the audience? What would you say to motivate them to do the same thing for this population, wherever they are around the world?
Yeah, I think anytime you're talking to management, I think one thing to note is just to know their style. Because I think all managers have different styles. Some people might be really data and factual based, and that's how you're going to get them to buy in. Some people are going to be more, give a story of why you think you should be seeing that population. I was just fortunate enough with Michelle that Michelle's is really great at like taking our ideas and running with them. Like she supports us a lot. So I really blessed to have a manager like that. But I will say different managers have different styles. And some managers are harder to crack, I think, or not open-minded, I will say. So people who are maybe not as open-minded, I think really understanding how you're going to get buy-in from them and kind of going in that approach. So, and just be confident. I think that's another thing is your confidence and doing what you're doing. Because I know for me, even having Michelle on my side, I kind of sometimes struggled with my own confidence on presenting to the doctors or the nurses, or honestly being on this. So, but I just think just knowing you have the tools, you are equipped to see that patient. Yes, we all need more training in what we do. That's why we're therapists. And just keep going. Don't take no for an answer. Just keep going. If one door closes, try another door. Yeah, that's my advice.
Excellent. Rachel, as a team lead, to other team leads that might be in the audience or our virtual audience, what's your why that you would like to leave to them about seeing this patient population from an OT and PT perspective?
Yeah, my advice would definitely be consistent as an occupational therapist and other occupational therapists out there. You know that your job is important as an occupational therapist. So just continue to advocate. So be consistent when you're talking to your manager, be consistent when you're talking to the doctors, to the nurses, of explaining why it's important for these patients to get these occupational therapy services. So my advice would definitely be just be consistent. Continue to stick with it and know that your role is important and you're going to make such a big difference when you finally get in there.
Awesome. Sarah.
So I guess my advice would be kind of similar to Jasmine. Just don't undervalue yourself and your knowledge and the skills that you have. Do you probably need, if you really want to start working with this population, more education or, to make an effort to learn more? Of course you do. But please, please, please don't undervalue the knowledge and the expertise and the skills that you already have, because I guarantee you have more that's applicable to this population than you realize. And my other piece of advice, and just what I really want to beg people to do, is please, please, please collect data. The hospital systems collect so much data on a regular basis that is just rich for research and analysis. And so if you do start a program, I don't care how you do it or who you work with, but please, 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 collect data on what you're doing so that we can get out there and get more of this published.
Sarah, anything in particular that people should be tracking?
So the things that I'm most interested personally are kind of the big metrics that hospitals tend to be very interested in. But I think you can really, this is another way to kind of pitch to your hospital, is what is your hospital really interested in? Are they struggling with readmissions? Are they struggling with infant drops? Are they struggling with falls? Are they struggling with patient satisfaction on their postpartum unit? So some of that can be tailored to what your hospital wants, and that's a great way to pitch your idea. But some of that those are just metrics across the board that, like, nationally are collected by every hospital system that are really helpful. They're just kind of quality assurance QA metrics that we take that I think would be great. So I would start there.
Awesome. Michelle, can you bring us home from a rehab leadership standpoint? What would you want to share to administrators, to other rehab managers, to leadership teams that are receiving requests from their therapists? I want to start this program. I want to serve this population. What's your advice?
Gosh, I think, appealing to the people part of it is so important to me. I think just being able to listen. Yes, I have amazing ideas brought to me, but if I didn't have the skill to listen to them, it would be all lost. So I think a lot of it is being able to listen, and to Jasmine's point, don't take no for an answer. And it's okay. I think being able to, for me, like, drop my ego a little bit and be able to detach sometimes when you hit those barriers, because it's inevitable. And being able to step away and then take your breath, do whatever you got to do, and then come at it with that curiosity. I wonder why, and then being able to connect with that person and then break down those barriers so that at the end, we all want the same result. How are we going to get there? And really come at things from a very collaborative standpoint. Because if you're trying to go in there with it my way or the highway, the results just aren't going to be favorable, timely, and relationally not really intact. So, I think those are some things that have been key for me. I have an amazing, amazing group of women here that have just paved the way, and I couldn't be more proud of them all. They're absolutely amazing people and professionals. And so they've made my job pretty easy, quite honestly, as we've walked through this. So I'm very grateful for them all. And for you, Rebecca, you've been absolutely amazing, guiding us and being an expert. You're just amazing. Absolutely amazing.
Mm-hmm. I can't thank you all.
One quick note I will say is take Rebecca's online course.
Absolutely. Absolutely take the
And if you can't have her come to your facility, I would say that course is great. So that provided me with a lot of information, and I'm just a hands-on learner. So I was like, Michelle, we got to get her here. But the online course is enough for you to feel equipped that you can go and have the knowledge to be with this population. Because I will say my sessions is a lot of education, more so than moving. Yes, we are moving, but it's a lot of education. So I will say taking that course is what you need to do.
Jasmine, thank you for that. And thank you all, really. I don't say this lightly, and I'll end here. I really, truly believe that you're making history. This is history. We're living it. We know the outcomes in our country. I think that probably drives me the most. And I just cannot thank you enough for not taking no for an answer. I think you really are changing history and you're transforming lives. And thank you for your time tonight.
Thank you.
Yeah.
Thank you so much for having us.
Thank you, Rebecca.
Yes, thank you.